Hello, Charlie Krasner here. I'm here with Jessica. Mike Stander has taken a vacation from his retirement, so he's not here today. Anyway, before we get going, I want to say, I hope some of you are eating pork sandwiches. Anyways, we have some really interesting stuff that I think you'll find interesting to discuss, as particularly infection control people. Some of the things that we've accepted about the flu vaccine, etc., and may not be true, but for treatment and diagnosis. And so I thought we'd just look at some fun slides first. And, so why don't you click on that first? All right. So neurocysticercosis is, besides the word you may get in a spelling contest, neuro means brain, cysticercosis just means cyst on the brain, and it's from the pig tapeworm. And so I just, more for entertainment, give you a little, make sure you get the heebie-jeebies. I'm going to review, so you know, there's a cow tapeworm and there's a pig tapeworm. And the difference is that in the pig tapeworm infection, there's an intermediate phase. So the humans are the definitive phase. They have the tapeworm. The cow gets infected and develops cysts, and then the human eats the cyst and gets the tapeworm. So we have, it's human to pig to human again. So if you look at the very beginning there, you see up the top left, you see the guy's eating a sandwich, and this is a picture of what you're seeing there is some like shish kebab or something. Anyways, you see all those white things. Those are the cyst form of the pork. So you enjoy it, you eat those, and it goes into the human, and it opens up and develops a tapeworm, which you see the tapeworm on the right. We'll go just a little bit. And so the cyst opens up and goes within the intestines of the human, okay? It doesn't go outside of that, and forms these tapeworms, which are about as long as 30 feet long, and you pass them in your stool. So in this country, you are, you know, the stool goes to a sewage plant and gets eliminated. But in developing countries, oftentimes it's just thrown in the back, and you can see. So the pigs that are hanging around eat these pig tapeworms. The pig tapeworms then open up and they go inside the body. They migrate through the body, these little worms, and they form cysts in the meat of the pig, throughout the pig. The pig is then slaughtered, and the cysts survive in raw, undercooked meat, and then gets ingested by the human, and then becomes a tapeworm. Okay, so it's two-stage. The human eats the cyst of the pig. The cyst open up, develop the pig tapeworm. It passes in the stool. The pig then eats it again. The tapeworm egg becomes a worm and goes throughout and forms the cyst. And so it's a cycle. And so this doesn't happen in this country because we have sanitation. But what happens in other places is that the pig tapeworm is released, and somebody who is a carrier of the pig tapeworm may then prepare food for somebody. They itch their butt, and these eggs, these little parts of the pig tapeworm, are given to your food, and then you eat it, and you get the. I'm sorry. So the human, somebody has pig tapeworms. The person, instead of eating the cyst, gets the actual tapeworm on the food. So then the pig tapeworm goes into the human and becomes the cyst, and opens up and becomes the worm. So instead of the pig eating it, the human eats the tapeworm, because somebody who prepared the food, or however you were exposed to it, you're now in the intermediate phase. And so so if you're eating contaminated food, you don't have to, it doesn't have to be pork, it could be any type of food. So somebody who has a pig tapeworm touches your food, maybe whatever it is, pizza, whatever they serve you, and that you eat that, the tapeworm, and the tapeworm then becomes the intermediate phase and enters the body. So if you go to the next one. A little bit confusing here, but.
So you eat the eggs of the tapeworm, right? Is that what it is?
Correct.
Okay.
You eat the eggs of the tapeworm. Okay, you're not, and the egg, so then it goes throughout the body. So this is this is called measly pork. So this is, for example, the pig eats the eggs hatch, and then they become these worms and goes throughout the body. It gives you this measly appearance. And this is measly meat. And if you were, then you could make pork sandwich out of this. You'd eat that, but you don't get the tapeworm. But what happens is that the human is now ingested. Instead of being measly pork meat, next one, you get the measly human brain and throughout. So the human now becomes the intermediate phase, and you get all these cysts, living cysts in the brain, the muscles throughout the whole body. And so this is called the measly human brain. And these things in the brain usually don't cause problems except when they die and they get this inflammation. The inflammation causes seizures, etc. And this is the most common cause of seizures in Latin America. Is someone who's consumed the eggs from a tapeworm. So next picture. And so this is the MRI. So on the MRI on the left, you can see the little cyst as the human. So this is a living cyst you've seen on the left side. And these things, when they start to die off, can cause inflammation and seizures. But when they after they finally die off, after years, they become calcified. So this one on the right shows calcification. So these are long dead cysts, okay? And so most of the time, you don't want to treat these because they're not living. The ones that you would treat would be on the left if somebody was recently infected, when they have all these cysts where you want to treat them. So in this patient, when they talk about calcifications is like petrified wood, okay? So it's been long dead, there's no indication for treatment. So this patient actually turned out, when they did a more detailed MRI on the patient, there was no calcification, it's probably just sclerosis. So anyways, that's what it is. So neurocysticercosis is the human acting like the pig, because that person was exposed not to infected meat, but infected eggs from somebody who was a tapeworm carrier. So we were just talking earlier, there was a famous outbreak in New York City where some Hasidic Jews are extremely kosher, don't eat any pork at all, and they had a Latin American housekeeper who was a carrier of the tapeworm, and she prepared their foods, and so they ate the prepared foods, and they developed neurocysticercosis. Okay, so in this history here, this guy likes carne asada and stuff. So carne asada, if it was infected meat in Mexico, he would only get the tapeworm. He wouldn't get the cysticercosis. So it's sort of fun. All right, so turns out, just like the brain is full of all these cysts, if you took the whole body, all the muscles in the body, not just the brain, would have these cysts throughout them. So if you were to take a picture of somebody's like thigh, you could see the calcifications, or the arms, you could see it. And the antibody titer, since they've been totally exposed, will be positive. So if you're concerned about neurocysticercosis, just do a serum cysticercosis titer, and that should come out positive. And it turned out, while the CT scan they thought was calcification, the MRI didn't show, and the person's antibody titer was negative. So this patient did not have neurocysticercosis. But again, it's very common. Probably once a year I get a referral for somebody who has either seizures related to this or some issue like that.
We had two last week here or now. So but I hadn't had any in the last year or so they come and go. But they're there.
It's creepy, huh?
All right, any other questions about that?
All right, so look carefully at that pork sandwich you're eating. If you feel like it's like crunchy there. All right. Anyways, so on a more serious note. So I did some literature review of the last 2 months, looking at issues that are really interesting, bring up a lot of interesting questions. So this first one is, people always say, when's the best time to get the flu shot? I don't know. I said, just get it, okay? And, at our VA, there's really big emphasis. Get these people treated, get it as soon as we get it, which may be August. You have the CVS and all the pharmacies saying, come in and get it immediately. Get it as early as you can. Just get it done. And, I mean, it improves the the vaccination rate, but the question is this really good for the patient? And so this was the question is, when is the optimal month to get a flu shot? Does its effectiveness decline over time? And this was just republished. It was called the Intraseason Waning of Influenza Vaccine Protection, Evidence from the U.S. Influenza Vaccine Effectiveness Network, up to 2015. So right now, they say, everybody says, oh, the vaccine has a 50% effectiveness in preventing the flu. So when you're talking about effectiveness, I looked it up, it means that if somebody got exposed to the flu, the question is that person going to go, has a flu vaccine and gets exposed to the flu, what is the likelihood that he is going to, how much benefit is it going to be in terms of that person not going to a doctor or urgent care to get treated for symptoms of the flu or end up in the hospital? So if 50 people are exposed to the flu and 25 of them ended up without the vaccine going to the doctor, if 25% of them ended up going to the doctor, so half of them would go to the doctor with flu symptoms. Then if you vaccinated another 50 and only 12 went in, so you would have a 50% effectiveness as you went from 25 sick enough to go to the doctor down to about 12. Okay, so that'd be effectiveness. So effectiveness means how much does it reduce the risk of the fact that you get symptomatic disease? You have to go to the doctor, get hospitalized. And so they looked, right now we say there's about a 50% effectiveness for this year in the flu. So the effectiveness, however, for B declines about 7% per month in vaccine effectiveness. For influenza H3N2 is about 7%, H1N1 was about 6 to 11%. So that means, let's say, we'll just take 7 as an average. So it's 50% for H3N2. When you first get the vaccine, it's down to 43% after 1 month, 35. So that tells you that after about 6 months, 6 times 7 is about 40 to 50, these vaccines have no effectiveness at all. So this, if you get an injection in August, and 6 months is maybe January or February, and so it really has no effectiveness at all for these patients because the effectiveness continues to decline every month. And so the person, there was a discussion on this, and they said, if you get mid-October, it takes about 2 weeks to kick in. So they thought mid-October was probably the best time to get a flu vaccine because then you'll be working by November and should last a few months. We've been seeing an outbreak of the flu going on now. You sort of wonder, is it because it's been 6 months since everybody's been vaccinated and now we really have no vaccine efficacy at all? So I thought that was interesting. Because I always say, just get your flu vaccine, get over with. But this would suggest that maybe waiting till mid-October and so that by November it'd be effective. Any thoughts about that, or?
Well, I have.
Yes.
We used to always in October, early November for vaccinating.
Yes.
However, when the drugstore got to play, the patients have come in and know, hey, we've given it over at Walgreens, I want mine now. So they've made it harder for us to maintain that October timeframe. Just to come.
Yeah.
And I think a lot of, I procrastinate. If you tell me October, I probably wouldn't give it until November. And I think that is largely behind the push too, is you can get more people vaccinated. Usually if your flu season occurs at the beginning of the year, which I feel like it's here at the beginning of the season, which I feel like it has the last few years, but maybe not.
Not this year. We didn't get anything until like January or February, right?
There's few really severe cases.
We had a few severe cases early on in the season, and then they dropped off, and
Now there's another second wave going on.
there is. Absolutely.
Yeah, so everybody, it's crazy. It doesn't work.
You're right. I think the answer, as you said, better vaccines.
Better vaccine, yes.
You can't win.
Dr. Krasner, a question I have. So after someone has flu, say they didn't get vaccinated,
Yes.
how long would you recommend that you wait to vaccinate them if they receive like Tamiflu for treatment?
I don't know that answer. But they also found that if you got influenza B, you may not get influenza B that season, but you're still at risk for influenza A.
So you still need vaccination after, even though you
I
have the
would
flu
think so.
because you have
Yeah.
other strains. Like,
Yes.
And I wouldn't think the Tamiflu would matter since it's not a live vaccine. Most of the vaccines aren't live.
When I looked previously, I couldn't find anything, so I was wondering what your
But I don't know,
recommendation
maybe your
was.
immune system is so revved up, it's not gonna respond to these other things.
Could be.
All right, so anyways, that's disappointing.
Does it get better?
All right, oh, sorry. All right, so this is another one of those, 10 Commandments. Oh, probiotics are good, okay? And so this was a few interesting articles just came out about the role of probiotics. How can probiotics be bad? They're natural and stuff like that. And so this first one came out in Gastroenterology last month. And it says, the name of the article is Timely Use of Probiotics in Hospitalized Patients Prevents C. diff Infection. It's a systematic review of 19 studies. As you can imagine, there's no set probiotic regimen. It could be lactobacillus, it could be Saccharomyces. The dosing, everything varied. And what they concluded was that the overall reduction in incidence of patients on antibiotics given probiotics went from around 4% down to about 1.6% in the probiotic group. So they said there was about a 50% reduction in incidence in people given probiotics. And they said it was obviously, as you can make sense, most effective when given closer to the first dose and best within the first 2 days. After you waited 2 days, efficacy fell significantly, and various regimens were used. Okay, so this would seem to suggest that the retrospective study that probiotics were very helpful. But as you know, the guidelines, which haven't been updated recently, do not recommend their use. And so this is the foresight. Let's go to the concern side. So this was an article that came out of 2 separate Indian hospitals. And they had 7 cases of Saccharomyces funkymia related to use of probiotics. And so this was not just in one hospital, these were in 2 different hospitals. And this is just a pack, Saccharomyces cerevisiae, which means wine yeast. Yeah, cerevisiae. So they reported 7 different ICU patients at 2 different Indian hospitals, 2 neonates, 5 adults. They were given Saccharomyces cerevisiae packets as prophylaxis for antibiotics, and they developed funkymia, all with the same Saccharomyces. They did isolate the blood, and they compared it to the product given the patient, and they were the identical products. So the genetic testing showed that this was not a different unrelated infection. All responded to probiotic antifungal therapy, and the authors concluded, we recommended avoiding this probiotic in critically ill patients. And so this was Saccharomyces cerevisiae. Then next. So this was another one, Saccharomyces boulardii, probiotic-associated funkymia, questioning the safety of this prevented probiotic use. And this is, boulardii is the strain of Saccharomyces that's usually said it's probably the beneficial. And you can see in that little thing, there's some cute faces on each of the Saccharomyces. So this was a case of funkymia in an immunocompetent patient after administration of the probiotic containing this yeast. Genomic testing confirmed identical match between blood and supplement isolates. And the authors, again, questioned the safety of this preventive biotherapy. So I got exposed to this issue about 6-7 years ago. We had up on one of our wards. So he was a young man he was very debilitated. He was like quadriplegic, and nobody wanted to take him home. And so he basically spent months up on one of the wards, basically just, as a nursing patient. And he had recurrent C. diff. And so he got this episode of C. diff, and I didn't write for it, but somebody wrote for lactobacillus, which is, the Lactinex. And about 3 to 4 days later, he started having fever and chills, and lo and behold, he had lactobacillus bacteremia. And so that was our first, so maybe, something natural like probiotics may not be correct, and it's not just a benign thing. And, one possibility is that we don't hear much about it is that, probiotics are regulated as dietary supplements. So there's no responsibility, no requirement to report safety issues or complications. And so we may be very underreporting or not aware of as much that these kind of bacteremia or funkymia or bacteremia situations are going on. And it may also be that it may be the more sick patients in the ICU may have a greater stress on their intestines, so they're more likely to become funkymia. But as the guy I saw, he was just, just basically like a nursing home patient on the floor. He wasn't very sick at all with the lactobacillus bacteremia. So I think that's something you want to keep in mind.
Absolutely. I'm not a proponent at all, especially when your colon's inflamed administering probiotics. But I think we're getting a big pushback from our dietary department in particular.
What do they say?
That they're bringing it on board for certain patient populations in our ICU population through their route, not through the pharmacy route.
If anything, ICU people are probably the ones you not want to do it because they're going to be the most sick. They probably have, blood different. I mean, things are not right with their testing.
I think they're actually doing a study, if I remember correctly, an IRB approved study, looking at the differences in infection outcomes.
Yeah. Anyways, that said, there might be we'll have to see updated C Diff guidelines are coming out soon, right?
Yeah.
We'll see what they say. Yeah, so there's no free lunch, say, oh, take this natural formulation. You guys have any comments what you're doing in your hospitals about supplements? All right. Anyway, so you may want to question, if somebody gets sick, it may be that the probiotics are causing the problem. So this was an article. If you look at the guidelines, they say mild cases of C. diff give metronidazole in the hospital if they're sick. High Y can't really sick. You go with vancomycin. And my rule has always been, if you're sick enough to be in the hospital for C. diff, I usually go to vancomycin. And so this was a retrospective study from JAMA, came on last month. And it was called Vancomycin Tied to Lower Mortality in Severe C. diff. And so these guys looked at 10,000 patients with C. diff, and they found that overall patients treated with oral vancomycin had a 20% lower risk of death compared with Flagyl. And as you can imagine, the greatest benefit was in patients who had severe C. diff. It reduced the mortality from almost 20 down to about 50%. And in the mortality in the mild cases wasn't significant, but it was improved with the vancomycin. So even from the mildest cases, was suggestion that vancomycin was the better drug over Flagyl. Recurrence rate, if they didn't die, however, was about 16% across all treatment and severity groups. And so their conclusion was that this builds on existing evidence that vancomycin may be preferable to Flagyl, particularly in patients with severe C. diff. But as I said, I think just doing the oral vanco for every patient who's concerned about C. diff. And obviously, we talked previously, you want to make sure they really have C. diff and just not colonized. And so we're starting at 2 different hospitals, the VA and Northern Nevada. We're doing the toxin test to actually see if these patients have, actively producing the toxin or they're probably just carriers. And in the microbiology lab at VA, we have the Bristol scale. We tell them, do not set up the stool unless it's number 7.
See it.
I think we had it on that last handout. Yeah, and when you're looking at the stool, you can make sure there's no pig tapeworms in it. All right, so as I said, if somebody's sick enough to be treated in the hospital, I think vancomycin is reasonable. We'll have to see what the new guidelines say, but again, make sure you're not over-treating somebody who just has a diarrhea. All right, so this was another study, came out in Lancet Infectious Disease. We've talked a lot about not using fluoroquinolones as the drug of choice for the treatment of asymptomatic bacterial urinary tract infections. It really should be a second-line drug, not treating for too long, short course therapy. because C. diff really causes problems like drug resistance and C. diff. And so this was a look from London, England, about what was the relationship between fluoroquinolone use and C. diff outbreaks. And so in 2007, the United Kingdom issued national guidelines for controlling C. diff infections. They said avoid Clinda, cephalosporins, and minimize use of fluoroquinolones, plus obviously infection control measures. And what they did, what they found over the next few years, that C. diff rates correlate most strongly with the fluoroquinolone use, was much more important than the actual amount of antibiotic prescribing rates. So fluoroquinolones was the best predictive value of C. diff rates. And the fluoroquinolone resistant C. diff is the C. diff that's most likely they're going to cause, called a NAP1 strain. So it's a very virulent, bad strain. And so when you give somebody fluoroquinolones or wipes out everything else, this C. diff, which is resistant to fluoroquinolones, has the gym to itself and really takes off. And what they found was, in one region they looked at, the percentage of fluoroquinolone resistant C. diff, these NAP1 strains, dropped from 67% of cases down to 3% of cases from 2006 to 2013. And what it did was they also found that by eliminating this, it decreased secondary hospital transmission of this very virulent epidemic strain of C. diff. So by restricting the quinolones, you're less likely to select out for this NAP1 strain, which has a higher mortality and also much more likely to spread to other patients. Okay, so it seems like, if you don't even worry too much about antibiotic use, if you can really reduce quinolones, and it's pretty easy to do, at least in the outpatient setting, is don't use quinolones up front for urinary tract infections. Use macrodantin and Bactrim first. Don't treat for 7 to 10 days, and just do the 3 days, and it can really make a difference. And in the hospital, avoiding the quinolones, like I see patients on Vancomycin, they throw Cipro for double coverage. I guarantee you something, if a Pseudomonas is resistant to Zosyn, it's be resistant to ciprofloxacin. So you just watch the quinolones. Right? So their editorial comment was, restricting fluoroquinolones can not only reduce C. diff rates, but provide a shift away from these epidemic C. diff strains, and obviously also reduce development of other resistant bacteria. Have you guys looked at how much quinolones you're using here?
Not recently, but we have decreased significantly. But I think our uptick in C. diff was probably by bringing on PCR.
Yeah.
So I'm curious to see if we go back to the toxin, what our rates look like before and after.
And also is a NAP1 strain selection. Are we selecting out for it? Suggested. So Cipro is bad.
And
Levaquin too. This was an interesting study. In most hospitals, if you walk in the door, you're put on vancomycin, okay? And you go to the ICU. If you get better, the doctors are afraid to change things, okay, because they think it's working. If they get worse, you just add to it. So you have people like on vancomycin for a long time, okay? And so this was a study from Mercy Hospital in St. Louis, and what they did was they wanted a retrospective chart review of randomly identified ICU patients who were admitted and placed on MRSA antibiotics as part of their initial regimen. So initially given empiric vancomycin, all the patients before they started antibiotics had sputum and blood cultures done. And cultures in all these 54 patients were subsequently found to be negative. So these are patients who were started on vancomycin or whatever the regimen is, and they were washed. But there was no evidence that these people had MRSA. In 26 patients, half the patients, they were stopped within 48 hours. Maybe the culture was negative, maybe somebody else said you didn't need it. In the other half of the patients, 28 patients, these were continued beyond 48 hours. So continued on the Vanco for at least an average of 5 more days. And it wasn't that, they looked at what are called PASI-3 scores, which give you an idea of how sick these patients was. It wasn't that the patients who had the Vanco stopped earlier were not as sick, so they didn't probably need it, versus the 20. And actually the people who were stopped at 48 hours actually had a higher Apache score than the other ones. And there turned out to be almost no difference in ICU mortality. I think only one patient in the first group died. It may not have been related to it at all. So what they were saying is, so none of these patients had MRSA. They were all starting MRSA activity. And there was no difference whether or not you treated these patients for less than 48 hours or 4 days. So there's no change in mortality. So really, if you have no evidence of MRSA at 48 hours, there's really no reason to continue vancomycin coverage, okay? It's pretty easy to pick up MRSA, you know. You get in the sputum or the blood, it should be pretty obvious. So,
And it grows quickly too.
yes.
Yeah, definitely within 2 days.
So, but I said, the most thing is people start vancom. If they're getting better, they're afraid to stop it. If they're getting worse, they add to it. So that's something like antibiotic stewardship program may want to emphasize. And these guys were going to change their antibiotic stewardship program to make those recommendations. Okay, so MRSA should show up, and empiric treatment when you have negative cultures doesn't do anything for the patient. Just two more ones. This is, one of the things I think about antibiotic stewardship programs is that, we can give you great guidelines, the physician great guidelines, but if you're not making the proper diagnosis in the first place, it doesn't really help the patient. And this was an interesting study out of London where they had patients who were diagnosed with cellulitis in emergency rooms who needed IV antibiotics. And they, instead of starting them treatment, they sent it to a central clinic where an ID specialist was reviewing the treatment. And he found that, or she found that, the ID specialist found that 40% of these referred patients with diagnosed with quote cellulitis, they were given an alternative diagnosis requiring a different management plan. Okay, so when we diagnose somebody with cellulitis and we give antibiotic recommendations, the diagnosis is not correct, it doesn't do you any good. And this reduced the need for hospitalization, reduced recurrence rate. And as you can imagine, the most commonly misdiagnoses are septic bursitis, venous stasis, and osteomyelitis. And I have a picture to show you guys. So on the left, septic bursitis, it looks like red, like a cellulitis, but the knee is swollen, and so it has an infected knee, okay? And so the treatment for that would be aspiration of the knee, okay? Antibiotics are important, but aspiration. So these were people that would be called just a cellulitis, but they should have done something different. And one of the more difficult things is venous stasis. This is, the chronic redness of patients who have venous insufficiency, obesity, and other problems that are overdiagnosed with cellulitis when it's just venous stasis ulcers, venous stasis. All right, so just, again, the diagnosis is critical. And this is the last thing to talk about. There's this new HIV test out called a 4th-generation test, and it's worth trying to understand how it works. And this was an article, Time Until Emergence of HIV Test Reactivity. How long did it take for tests to become positive following infection of HIV-1? Implications for interpreting test results and retesting after exposure. I've been in this a long time, and traditionally patients are told we have to test you for 6 months. That's like a long time to be worried, to be stressed out. It's really a miserable 6 months for patients, particularly in the old days when there wasn't any treatment for HIV. And that was the prior generations, first, second, and third HIV generation tests only look for antibodies against HIV to make the diagnosis. And it can take months to finally get enough antibody in your system to be confirmed by a Western blot. Okay, so we're only looking at antibodies. You first get an infection, and then the body starts making antibodies, which can take weeks, and they get enough antibodies to confirm the diagnosis can go on for months. What's different about these new 4th-generation tests, while they look for the antibody, they actually can find the virus itself. So the virus goes into your blood, it releases particles, and so it can pick it up very quickly. And so this new 4th-generation test can pick up the virus, the infection, even before the body starts producing antibodies. And so the window period, so as early as 6 days after being infected, you can have a positive screening test. And by 44 days out, so about 6 weeks later, a negative test rules out infection 99% of cases. So this would suggest that you could probably stop 99.99% of the time you're going to be right by stopping at 3 months. Okay, I just had a patient in the hospital, and a young gay man, and he had gotten himself a blood test on January 28th, which was negative. He actually took it on his cell phone. He had anal intercourse with this guy like a week later, and then he came in to our hospital about 3 weeks after that. We actually also him in the hospital, and he was sick as a dog, and his fourth generation test was negative for antibodies but positive for the antigen called the P24 antigen. We then reflexed over, the viral load was 10 million. And so we picked this guy up before he even had antibodies within 3 weeks of his infection. And he told the guy who had met that it was that he had probably got infected by him because he's the one we've been with. The guy said, no, it's not possible. It was too quick, et cetera, et cetera. But that was not correct at all. So this is called, I'm not trying to be a salesman, but this is the Allure HIV-1 antigen antibody test. So on the left, you can see that's the structure of the HIV virus, and P24 is just part of the nuclear material. So what it does is it picks up the virus particle called the P24, and it also picks up the antibody. And so on that, next to it says there's like a strip, and it's hard to see on the side, but it has two columns, one on the top, one on the bottom. One looks for the antigen and one looks for the antibody. So you may have a positive antigen line, a negative antibody test. You should pick it up really, yeah, very good. So it says antigen up on top and an antibody on the bottom. So you may see an antigen positive, antibody negative with this combination test within 7 days. And certainly within 6 to 8 weeks, it should be a negative test is a negative test. All right, so this is the test you want to get. I'm sure somebody else makes it, but this is just wanted to show you exactly what we're doing with this new test. And so this was basically stop HIV testing at 3 months with the new 4th generation test. You get exposed day 0. By day 16, 95% of people will have the antigen in their blood. Within about 3 weeks, exactly what we have with our guy, they'll get symptoms. He was extremely sick. And by day 28, 95% of people who will be positive. And by 3 months, more than 99.97% of patients will have their test will be positive. So this is the best test to use. I don't know if you use old ones. Are any of you guys using these new 4th generation tests? If you do send it off to like Quest or LabCorp, this is the test that they will do.
Is this very,
Say again?
is this expensive?
I'm not sure. I don't think it is that much, not more than the other test. Do you know how much it is?
I don't know how much it is. We moved to the 4th generation ever now.
Yeah.
You know.
I would guess probably about $20 or something like that. Not too much. But it is the best test to get. And again, it relieves anxiety and gives you a diagnosis really quick.
Are there false positives?
Yeah, there are false positives. So you want to wait until the final test result comes out, okay? There's a long pathway that they follow. And we had 1 or 2 patients who had, they were read initially as positive, and then the confirmatory test actually, sometimes that P24 thing can be false positive, and they have to reflex it to the virus itself. So we've had some ugly incidences where patients were told before the test was finalized that it was positive or actually turned out negative. But the final test result is accurate, will be accurate.
This would have a place with occupational health.
Yes. Yes.
Okay. I have the next 2 slides. One of the last, at the last Echo Clinic, somebody sent us a question afterwards and asking that she had heard recently an ID physician from the University of Minnesota say that people should stop taking their antibiotics after they feel better. They don't need to complete all antibiotics prescribed by physicians. And this was said by an ID physician. And the question was, is this true? And and is this something we should be telling our patients? And I think as a general rule, this applies to outpatient treatment of common infections that probably should not have received antibiotics in the first place, is my 2 cents on it. And if that decision is made, it should probably be in conjunction with the physician. But I put up here a list of the next this slide and the next one, this is what we hand out at Renown. This is guideline-based duration of therapy for various infections, inpatient as well as outpatient. There are certain infections that are probably not on here because they don't need antibiotics, for instance, bronchitis, or non-group A strep pharyngitis. Antibiotics are not recommended for treatment of those infections. Some asymptomatic bacteria you don't treat unless their patient is pregnant or about to undergo a urological procedure. The treatment, as Dr. Krasner says all the time, for cystitis, for uncomplicated cystitis, is as little as 3 days, at most 7. For quinolone, it's absolutely 3 days, no more than that. Macrobid being 5 days. For even pyelonephritis or complicated cystitis, you can go as little as 7 days in a lot of patients if they're quick to respond. If they're slow responders, you might extend it to 10 to 14, but 7 is sufficient for most patients. Group A strep is one of the few indications that we actually go longer than 7 days these days. It's actually pretty rare to go beyond 7 days. But group A strep, because you treat for longer to remove that colonization that in theory has been shown to prevent development of rheumatic heart disease, glomerular nephritis, those immunologic phenomena. Patients oftentimes start to feel better before the end of that 10 days, but we would like them to go ahead and complete the full 10 days. Pneumonia, another one that I think a lot of times people overtreat. So 5 days you can treat as little as 5 days, and that's probably sufficient to treat most pneumonias, even the ones that are hospitalized. And I imagine that's about, usually patients start to feel better around day 2 or 3, treat for about 48 hours after they start to feel better, and stop around 5 days most of the time. Sinusitis, I think this is another thing that people always treat for longer, if it requires treatment at all. Very few sinusitis actually require treatment. They have to be symptomatic for something like 10 to 14 days, or have a double sickening or very severe symptoms for there actually to be an indication to treat sinusitis. And you'd only need to treat for 5 to 7 days unless it's recurrent or they failed with first-line therapy, and then you may go 7 days up to 10, but 5 to 7 for most patients. Skin soft tissue, very similar, depending on if it's complicated or uncomplicated, and whether or not you need antibiotics at all if it was a simple skin abscess, if you provided IND. So these are just some examples. You're free to take this information. If you see any mistakes in it, please let me know. Just shoot me an email or call. But these were all based off of guideline therapy. So you have any comments?
Good.
Okay. Any other questions? Okay.
So flu shots later in the year. Big question, probiotics. If somebody's got negative MRSA in their cultures, stop the Vanco and get the HIV, 4th generation HIV test, so people don't worry for 6 months.
Don't. Watch your durations of therapy.
Yes, and really focus on the quinolones, getting rid of those quinolones. All right, thank you all.
Dr.
Yes.
Oh,